Hello, everyone. Welcome to our journal club for September. Very excited to talk about sports-related concussion and assessment tools and related concepts. So we're very, very excited to have Dr. Jennifer Broswell Christy with us as our special guest, who is an expert on this subject. So we're getting her insight. I'm going to let Dr. Christy introduce herself.
All right. Thank you. Thank you so much for having me. This is super exciting. I'm so glad you chose our article for this journal club. And I'm the DPT program director at UAB and also a vestibular researcher. And my passion is in working with children with vestibular hypofunction. So this is not exactly that, but I joined an amazing group of researchers who wanted to get some fancy equipment that you read about in the article and to test our UAB athletes to see if we could pick out something that was objective related to concussion. And of course, since we know that many symptoms of concussion are vestibular related, we thought, okay, let's measure the vestibular system. So I'm excited to delve into this article with you all today.
Perfect. Thank you. All right. Well, we'll be checking in with you as we have different areas to discuss here, but I'm going to kind of roll forward into the article. And here we have beautiful Dr. Christy again, as you can see. And of course, the article that she mentioned, you should have all received. If you didn't, please feel free to email sales at vestibularfirst.com or support@vestibularfirst.com, whatever is easier for you, and just let us know you need the article and I'll make sure that you get it. So the article we're discussing here is peripheral vestibular and balance function in athletes with and without concussion. And that was published in 2019, so very recently. And the purpose listed in this study is essentially there were three different purposes listed. One is to evaluate the test and retest reliability and normative data on vestibular and balance tests in athletes without sports-related concussion, which is pretty interesting that that hadn't really been done, or maybe you were adding to that body of knowledge.
Yeah, so one thing that we really wanted to do was to collect our own normative data and to look at the reliability of the test, because that has not been published anywhere. And so we just felt like that was important to contribute.
Definitely. I mean, that baseline kind of assumed basics, it's like we need to know like what we're working with in order to assess anyone with concussion, right? Secondly, you wanted to compare athletes with and without sports-related concussion on the subtest. And we're going to be talking a bit, and we're going to get more insight from you on the different kind of vestibular tests that are done, kind of an instrumented sense, we'll say. And then identify subtests for concussion testing protocols. Because as you mentioned, it's really important, to try to figure out how do we assess really anyone after concussion in an effective way, right?
Absolutely.
So the tests are performed on folks between the ages of, I believe it was like 17 and 24, something like that, as I recall from the article. So I think the mean was like 20.6 or 20.7, depending on which group we were talking about, for those healthy athletes and then athletes with sports-related concussion. And some of those were tested twice, and that was part of that reliability study. First thing up was the Rotary Chair, which I'm going to kind of give my understanding of it, and then I'm going to let Dr. Christy go to the next level. In a basic sense, we're assessing peripheral vestibular function with that, and it is considered the gold standard for detecting a bilateral vestibular loss. So we want to kind of talk a little more about what rotary chair testing is, what it looks like, anything like that you want to cover. Go for it.
Yeah, so the Rotary Chair is this big piece of equipment that places the participant in the complete darkness. There's not even one little bit of light in there. And that's important because any light can affect the test result. And we use video nystagmography, so we put video goggles on them, which I'm sure everyone has seen. And therefore, we're able to measure the eye movements with infrared technology. And we do the rotary chair actually allows us to measure not only vestibular function, and it only measures the horizontal canal because we're just moving side to side like this. It doesn't measure the anterior canal, the posterior canal, or the utricle saccule like the VIMPs do. But it allows us to look at oculomotor abilities. So we can measure the saccades and the smooth pursuits. We can measure optokinetics. We can do VOR cancellation. So we can measure some central tests as well as subjective visual vertical, which we'll talk about in a minute, I'm sure. But the rotary chair tests include the sinusoidal harmonic acceleration test, which is just where the chair is moving side. Luckily, I'm in a rotating chair, side to side like this. Okay, and so we move a little faster, maybe a little slower. And so we're able to get the full range of frequencies up to 1.28 hertz, which is pretty fast, like this. Okay. And so we're able to measure the VOR, so the eye movement response to the head movement. And so we get the gain of the VOR, eye movement velocity over head movement velocity. And there's norms for that. And so we do that. And then we do another test called the step test. And that's where the chair spins for 60 seconds and at a constant velocity. So once you reach a certain velocity, it maintains that velocity. And we're looking at the time constant there. And so we're looking at per rotary and post rotary time constant. So that gives us an idea of how the VOR function.
Perfect. That's a great summary. In addition, you all looked at the CVEMP, which is designed to assess peripheral vestibular function, specifically the saccule and its afferent pathways, right? So it's kind of a mixed bag when I think about that, but anything you want to add about the CVEMP testing?
Yeah, that's correct. So the CVEMP, it uses sound that stimulates the saccule, and it's an inhibitory response to the sternocleidomastoid. So all the participant has to do is turn the head, activate the muscle. We introduce the stimulus, and you get this beautiful response of the saccule. So you're able to look at that vestibulocholic or that vestibulospinal reflex.
Perfect. And the sensory organization test, that requires a certain instrument and tool, right? So I believe you use the Equitest. The other one that I'm familiar with is the Neurocom Balance Master, right? So those are kind of the two big ones that I'm familiar with. I know there's probably one or two others out there as well. I think Burtec has a version. So in that test, eyes open, eyes closed, stable or a moving platform, and then stable or a moving visual field, we'll say, in a variety of ways that could be presented, right? So 6 conditions total. Got that right?
Yes, and I think it's important to recognize that, you know, we're looking at 2 different things here. So we're looking at the rotary chair test and the VEMP, which is looking at peripheral vestibular reflex. All right, so that's actually looking at the connection between the inner ear through cranial nerve 8 into the vestibular nuclei and its connections into the central system and those reflexes that come out. But the SOT is looking at your ability to take in that sensory information, integrate it, and then produce that motor output. So it's looking at how well does the person use vision, somatosensory, and vestibular for balance.
Perfect. Great. All right, so hopefully I captured some of what you described in detail here as far as the purpose of those kind of subtests of the rotary chair. So let me know if I need to adjust anything in my slides.
Yeah.
So you talked about that sinusoidal harmonic acceleration, which sounds unpleasant, at least at the faster frequencies. I don't know that people would necessarily enjoy that if they have vestibular issues.
It's in the dark. It's not that bad.
Okay, that's good to know.
You know, you can't see. You basically, you do get dizzy if you have vestibular function, but it's not as bad as you would think because you're in the dark. Now, people with concussion did not necessarily like it. You know, there were, as we put in the article, there's a few people who didn't tolerate some of the frequencies, and so we stopped the testing for them.
Got it. And we know VOR cancellation, if that would be abnormal, that would be a central sign. The velocity step test, again, looking kind of at those vestibular peripheral asymmetries, primarily that optokinetic nystagmus, which I guess it could be also called visual enhancement gain. Are those interchangeable? Is that correct?
So optokinetic nystagmus is just where the chair is completely still and you have the lights rotating around. So it's looking at involuntary smooth pursuits. So you're looking at a gain of the involuntary smooth pursuit. The visual enhancement is where the chair is moving at
Ah,
0.6
okay.
hertz and you have some light in there. So you would expect that your gain would be a gain of 1
I see.
normally
Got it.
because there's some light introduced in there.
But they both would help identify central signs if they were abnormal. Is that correct?
It is visual, well, visual enhancement is vestibular visual integration, and then optokinetic is purely visual.
Got it.
Central, yes, central visual.
Good to know. All right, that's a good differentiation. Thank you for that. And then, of course, our favorite here, the subjective visual vertical and horizontal. That's our perception of vertical and horizontal in the absence of other visual cues. And I read that it was mediated by the utricle, which is a peripheral organ, and the central utricular pathways. So kind of mixed in that sense. Is that correct? Kind of touches on both. Is that what I'm seeing here?
Yeah, so someone with a peripheral vestibular hypofunction, right when they have their vestibular loss, they will demonstrate some SVV abnormalities. So they're going to perceive that they're tipped and that their world is tipped, but that typically will resolve very quickly for someone with a peripheral hypofunction. But as you know, what we found, and we'll discover this later in the article, is that the athletes basically just didn't know where they were in space, the people with concussion. And so they had a really increased variance, which we think is, again, that central integration function. So SVV is coming out to be a really great test of central also.
Yes, that is very exciting for sure. All right, so for the reliability portion of your results, there were some good findings on reliability for some of the tests we just discussed. And for the higher frequency sinusoidal harmonic acceleration and the VOR step tests, that they said it kind of was better if there was repeat testing. Did I understand that correctly for the reliability?
Yeah, with the the higher frequency harmonic acceleration, that doesn't take very long to do. So it's just kind of back and forth a few times. So that one would be easier to repeat. I'm not sure that we really need to repeat it. Reliability is based, these ICC values are based a lot on the variability between the data. And if you have data that's super, super tight anyway, it's hard to get a good ICC statistically. But the Shaw test, you would not, the step test, you would not want to repeat that one because you're spinning and then you stop and then you spin the other way and you stop. But what we can average is the pre-rotary, the post-rotary, the per-rotary, and the post. We can average the 4 parts of it.
The pieces of the step test.
Reliability.
Very cool. All right, that's helpful to know. All right, good. Luckily, I don't have to run these tests, but it's good to get the right information out there for those who might. All right. So what the results showed from the athletes with sports-related concussion perspective was that they had significantly worse scores on the VOR cancellation gain, the subjective visual vertical and horizontal variance, and all conditions of the SOT. So we'll talk about different ways to measure subjective visual vertical, for example, and I just kind of put this up to have an image of a very wonderful app that was designed by Dr. Graham Cochran, who we were pleased to also have as a previous guest on our journal club. So if you guys have an Android and are able to check that out, I do recommend looking into that as a kind of alternative way to kind of objectify subjective visual vertical, because there are different ways to measure it, which we'll get into a little bit more in a moment. But that was kind of the summary from the findings. So the discussion, and I'm definitely interested in Dr. Christy's input to make sure I've got this right, was that basically concussion does not appear to impact, in general, peripheral vestibular function. And that was kind of like a summary of kind of what those findings gave the team when they were looking at this kind of athletes with sports-related concussion and all of this peripheral vestibular testing, what was happening there. Now, I know it didn't specifically look at or discuss BPPV. I think Dr. Christy and I can agree that that's something that if you have a patient coming in your door, you should still check for that because it is not uncommon to have that be something present, and it's technically peripheral. So just kind of want to put that in there. But I know that wasn't
actually,
the purpose.
I have a story. One of the athletes came in with dizziness, and I, was taking him through the testing battery. He did fine on the Rotary Chair, the VOR. I take him back for the vamp, which requires you to kind of lie back. And, and when I sat him up, he said, I feel like I'm spinning. And I'm like, all right, I can treat you right now. So I just treated him, did the CRM, and he was fine. So yes, if your athletes are hitting the head, there's a good chance they could have BPPV.
Don't forget about BPPV. All right. But again, not the focus of the study, but just one more piece of the fairly large puzzle sometimes that we're dealing with these folks with concussion, right? The other piece here is kind of looking at the central pathways, right? So kind of what's going on there, and the tests that kind of touched on those pathways that were abnormal kind of seems to all kind of connect back to the idea that concussion does seem to affect these central vestibular pathways, which, makes sense, but it's nice to see, that kind of holding up on the testing. Is that kind of what you got out of that, Dr. Christy?
Yeah, and I when we started doing this study, I never really thought that we were going to find hypofunction in people with concussion. And, you read all these articles that say people with concussion have vestibular problems. They have vestibular dysfunction or whatever. But it's important that we know what that means. What did they measure? They measured the VOMs. They looked at the symptoms scale, which, that is abnormal, and that's a great outcome measure to do, but they did not measure, actually look at those peripheral vestibular reflexes. So, one of the things that I'm glad we did this. The testing is brutal, and so I'm glad that we discovered that you don't need to put your athletes through this testing, protocol, because, now there could be athletes, of course, who get hit in the temporal bone, and they could have peripheral vestibular dysfunction, but for the most part, they don't. So that's good news, because that means that they have a good peripheral vestibular system to be able to use, in their rehab as you're trying to get them to integrate it better.
Right. No, definitely. And on the flip side, for the occasional rare person that does have either a known or unknown but discovered history of hypofunction, and they get a concussion, which I've had those in clinic, it definitely can affect their ability to recover from concussion, right? Because now we don't have as strong of a peripheral system to draw from, right? So I think, that's why paying attention, and, we'll talk about kind of if I have somebody walking in my door, what I call fresh, meaning they've had almost no testing, maybe they just saw primary care, how we might want to approach those patients, when to refer, things like that, all good things to think about. But again, like you're saying, not everybody with concussion needs to go through like a full Rotary Chair battery necessarily, right? So, that take-home message is that when you're testing patients post-concussion, it could be helpful to assess VOR cancellation, subjective visual, vertical, and horizontal variance, and conditions on the SOT if you have access to that kind of testing. And we could talk about other options here. So for me, since I don't have, a Rotary Chair or access to one, and I have these patients, again, coming into me from a primary care, things like that, I might do what I'll call a non-instrumented VOR cancellation test. So the one that I'm sure that Dr. Christy has taught to students and at courses would be something like what you see in this picture, which would be kind of putting the arms in front, the thumbs are lined up. Keep your eye on the thumbnail, you have them turn, you kind of assist them at a certain rate, and looking for saccades. Anything to add on that testing, or kind of tips and tricks that you would say for somebody who doesn't have, that instrumented testing?
Yeah, so In the study, we were using the Rotary Chair with a light that they focus on. They focus on a red dot, and they were in the dark, but the red dot was in there. And the dot moved at the same speed as the chair. Okay, so it was just, the VOR cancellation test, and we're able to measure very specifically the gain of their VOR. And even though the concussed athletes had a gain that was a little bit higher than the healthy athletes, it wasn't like crazy, crazy high. So I'm not sure that you'll appreciate in everybody on a clinical version, you may not, which is fine, So if you do see an abnormal clinical test, then that's really bad. That's pretty bad. So.
Right. But if you don't see it, A, of course, it doesn't mean they didn't have a concussion, right? And B,
Correct.
It may be symptomatic for them, which is at least something to note.
And that's part of the bombs too, so.
Fitting it all together, right? Love it. All right. So for the subjective visual, vertical, and horizontal variance, the first thing I wanted to do for everybody, I know this is a little smaller print, sorry, is just to kind of make sure that variance makes sense. Because I had to kind of look at it again. Like, I'm not a statistical person, kind of forget some stats, So I want to make sure that what my understanding of the variance is correct, Dr. Christy. It is a measure of how far the data set is spread out, right? So a small variance means that all the numbers are pretty close together. And a high variance, a big number, means that the data that was collected were more different from each other. Is that a kind of a good interpretation of the variance in this case?
Yes, that is exactly right.
Okay, good. So in the sense of measuring this, it's about trials, right? So if you were to do a bucket test with somebody in your clinic, let's say, because you don't have a Rotary Chair or anything that would allow you to do it in an instrumented sense for some reason, you would want to do multiple trials. Is that something you would agree with, Dr. Christy?
Absolutely, because that's what we found in this study was that if you looked at the mean degrees off center, they look normal. But then if you look at the variance, you say, okay, they set it way over to the left, and then the next trial, they set it way over to the right. And so you do need to do, at least 10 trials of SVV. And then what you're going to do is record each trial and then look at the variance of the trials. So how much did it vary?
That's good to know, because it's interesting when I kind of tried to look through some other articles that did different testing on patients, whether it was concussion or otherwise, stroke sometimes. I was interested how some of them only did 3 trials, and maybe some of them were older studies. So I'm not trying to say they did anything wrong. They're probably trying to do the best they knew. But like you're saying, 10 trials would really be kind of your minimum.
Yes, yeah. So in this study, we did 3 to one side and 3 to the other side. So we did 6 trials. But we did another study that is actually published now in the Journal of Vestibular Research, where we looked at the reliability of Graham's Savvy app with the bucket, and we did 10 trials for that one. So, in this study, we did 6. We did 3 to each side. Definitely, that would be your minimum that you want to do. But I would say more is better to get the data that you want. And they were completely spread out. So, and this is something that we've seen not just in people with concussion, but Graham saw it in the people with MS, and we saw it. Anwar, my other PhD student, saw it in children with cerebral palsy. So it's like all these central kind of conditions, we're seeing this. And, what is this? Is it a kind of a central integration problem? Is it, a connection with the hippocampus? Like, we don't know. No one's really measured like what's going on with the SVB. Is it the sensory gating theory, which Graham talked about in his work too? So
right,
I think
right.
It's exciting. At least we have something kind of objective to look at. Not that we really know how to treat this, or do we really need to treat it?
That's a good discussion. We're getting to that. That's a good point. But just to make people feel comfortable, if they wanted to try to measure it, kind of knowing that they want to do those multiple trials. So I'm thinking for me, with my time frame, I'm going to do that day 2. There's no way I have time for that day 1 personally. with my patient schedule. So, at least kind of knowing what I would need to allot for it. And again, like anything, you're always looking at the patient saying, well, do I need to know this? What is this going to help me, do? And in some cases, I think the answer would be yes. And I think it sounds like, at least for athletes, since that's the group that was studied, I think for non-athletes, maybe, right? We don't have a study that I'm aware of on that, unless you have additional research knowledge that I don't, because you probably read a lot more articles than I do. But have they looked
I think
at
it's
that?
cool. Like this test was designed, to look at, okay, do you feel like your world is tipped toward the left or toward the right? But what we found is that, and I think other people have also found this, is that it's the variance is the data point that you need to look at. So
Good point. All right, very cool. All right, so looking at that sensory organization test, we talked about the instrumented versions for those of us who do not have access to that. There's certainly the original, what I did in school many moons ago, putting them on the foam and making some kind of paper lantern situation. I don't know if that's ever been validated. Maybe you have insight on that.
yeah, so for that one, what they have found is that you don't really need to use the dome anymore. You can just do the 4 conditions. So floor, eyes open, eyes closed, and then foam, eyes open, eyes closed. Now your athletes, you may want to go to the best, where you have them kind of do some more challenging things. Standing tandem and on one foot with the eyes open, eyes closed on the foam. If because most of the athletes will have a baseline of the best test. The modified CAT-SIB might be a little too easy for them.
Right, makes sense.
But you can do the dome if you want, to, but you don't have to.
Yeah, I mean, it's just, when you're trying to replicate an instrumented test, you're thinking, okay, well, do I need, yeah, you're saying, like, it's good to know you don't need to do that, although I guess you could. But I thought it was interesting, I was just happened to be, looking around as I'm, excited about all this information. And I discovered that at Ithaca College, they had done a study just published in July. And I don't know if you're already familiar with this, but they were using virtual reality as kind of a means of a dome, essentially, to create that visual conflict. And we're showing some feasibility for it, essentially. So it's definitely not like out there available to my knowledge to purchase or anything, but it seemed like they were kind of seeing if that was a reasonable way to, increase access, because clearly the Equitest and the Neurocom and Burtech are large and take up a lot of room and could be, expensive, or other barriers that might limit clinics from having it. So if this is something that's a good alternative to capture that as well, something to think about.
Yeah, I believe that, I think if you can afford a forced platform, I think that that's a good investment. Even if you don't have the big surround and everything, just to get some, sway data. But you can, as PTs, we know how to test balance, right? We can test balance, but you want to make sure you challenge the vestibular system, which would be a condition where they're on a movable or a compliant surface and with their eyes closed.
For sure. Good. A lot of ways to think about testing for folks who have variable access to different options, right? So treatment-wise, and again, this is definitely an area for discussion, but if I find somebody with a VOR cancellation deficit, sometimes I think that just by doing what I'll call regular therapy, which would be like kind of treating to functional issues, that may kind of rectify itself. But when I was kind of brainstorming about what activities do I do with folks that might be addressing this without me even always realizing it, these are some things I came up with. So, the simple, just toss the ball to yourself, either left or right to each hand or up and down. You're kind of working it that way. Marzen ball, which, as the letters on it, hangs from a string. You probably, worked with kids with those especially, but I've had lots of athletes be into those as well. So they're kind of like having to follow and track and, so it's kind of, sometimes it's a mix, right, of saccades and smooth pursuit and VOR cancellation that we're doing here. But, it's all good stuff in my book, from the central system, oculomotor and vestibular working together ideally. And then kind of fun stuff like bean bags and ring tosses. So do you have any other thoughts on, whether we formally address that? Is that just something we integrate into our treatment? What's your experience on that, Dr. Christy?
Yeah, I agree that I love your ideas. You should be a pediatric therapist coming up with all these fun ideas. But Yeah, this is something that we just do and function all the time. And so I think, just incorporating head movement with eye movement is in a functional way is going to be great to help with
Perfect.
this problem.
Good, good, good. And then when we think about subjective visual, vertical, and horizontal, and I would say just getting it more consistent so it'd have less variance. There's all kinds of cool kinesthetic training you can do, just kind of body awareness type stuff is what I call that, where there's just standing still and trying to tune into center, giving them more cues for somatosensory awareness. So your shoulders over here, let's try to get it straight. And then do we use visual cues with a mirror, or we use kind of the laser uh, on their head or a body part, an arm, whatever, and you can do some different things with that. They call that joint position error training sometimes. Of course, putting them on uneven surfaces to really challenge them, finding center again, right, which is more your traditional balance training essentially, and perturbating them in different ways with either the surface or maybe manual or whatever. So what would your be any additional thoughts on that?
Yeah, I love those ideas. The joint position error training, that's a great way to train body awareness, neck proprioceptive awareness. Because we don't really know exactly why they're having this SVV variance problem yet. But obviously they are having a hard time knowing exactly where they are in space or where their world is in space. So anything that you can do to ground them, to give them awareness is going to help.
For sure, for sure. And then you add the head turns and looking at different targets, and then that whole integrations part, right? That sensory integration, to me is the good one and the most fun.
Yes.
Cool. And then last but not least, again, kind of the sensory organization test, I think ties it all together. You're basically balance training 101 in a way, challenging that visual dependence, or you're kind of limiting visual input to try to, get them to still kind of find where they're at, providing visual conflict with the, static backgrounds or those optokinetic videos, lots of sources for those. I've posted a few examples up there in the pictures. Virtual reality stuff is definitely a hot topic. So have you had a chance actually to do any virtual reality type of treatment with either your athletes or your peds or anything like that? What's your thought on that?
I haven't, but I think it's exciting. I've seen the Vertec virtual reality stuff. It's really cool. I think it's just a fun tool that we can use to help people learn how to navigate their world in a safe environment. Okay, one thing before I forget, even though VOR doesn't seem to be impaired, I do think we should measure dynamic visual acuity. We didn't talk about that yet. Are you going to talk about that later? Or
No. I'm glad you brought it up. It wasn't really
Yeah.
highlighted in the articles. I think I was kind of
Right.
fixed in on that. But please go ahead and just bring it into the discussion. That's great.
Yeah. So DVA, there's been some other papers that show that athletes with concussion are having trouble with DVA. And the only reason we didn't measure it was because we had so many other tests. We could only test them so much, these poor people. And we didn't have the computerized DVA yet. But I think the computerized DVA, it's a great tool. In the same article that we did the reliability of the bucket test, we also did computerized DVA using the Vertec Visual Advantage. And it's a great test. So they have two tests. They have the dynamic visual acuity, which is where you turn the head at a consistent speed and they identify the E, and you get leftward and rightward. But the more challenging one is the gaze stabilization test, where you turn the head faster and faster and faster. And you really get a sense for, okay, how fast can we move the head and the athlete or the patient can still see the optotype. So even though their VOR is good, they may have abnormal DVA because of the central integration problem. And they might need some, VOR training for that. So some VOR times when viewing and exercises like that. So we didn't address that in the article, but I just wanted to make sure everyone didn't forget about DVA. It's like one of my favorite.
Definitely. Good to remember that. And I would ask you, of course, for the poor man or woman or person out there that doesn't have the computerized, even though it might be on their wish list, to measure it kind of the traditional way where they're reading the eye chart and then you move their head yourself and they read that eye chart again. Is that sufficient, or does that give us some information?
Absolutely. Yeah. I did a couple of studies with the kids where we used the chart, version, and it was reliable, and it did a really good job, the greater than 2 lines of difference. So yeah, use that chart. Now, of course, you have to make sure that you're not making them too symptomatic, because that is a kind of a hard test to do. So it might be one that you do later in your, once they are able to tolerate those head movements. But
Right.
I think it is important.
Absolutely. And I think that leads us right into this question, which is I kind of just threw down some stuff that you might test if you have someone walking in your door and you don't have a rotary chair or any other instrumented assessment. Again, the people who have them, obviously go for it, use them. They're awesome. Do not get me wrong here. But I am very sympathetic to folks who maybe are saving up for them or don't have them. Kind of what would be kind of an ideal, if there's such a thing, concussion assessment. And I'll just open this out by saying that you're not necessarily going to do all of this the first day, especially as you've already just pointed out, depending on tolerance to, different, kind of how they're coming in symptomatically, neck, like if they have major neck issues. I think DVA might be something that sometimes they're too guarded to get a good assessment on, let's say, for example, or you don't want to scare them off with it. So, do you have to be judicious on your testing? So I kind of just put this out kind of out the top of my head. I might check. So the VOMS captures a lot of this, by the way. Saccade, smooth pursuit, Vieira cancellation, convergence. And I know that there was a recent kind of article and discussion about doing the VOMS after some supervised exercise. Are you familiar with that study?
I'm not, but I want to be.
Yeah, no, they really just were putting it out and talking about a little bit on, I forget if it was the podcast that the Vestibular SIG puts out now and then or something like that. Anyway, it was just kind of something was suggested that sometimes if you do the VOMS, not in an athlete that maybe had their concussion a month ago or whatever, that it might seem okay. Versus if you had them do a little bit of supervised exercise and then did the VOMS, I'm sure this doesn't surprise you. You might get more, not that you're trying to provoke findings, but you're just trying to really get a sense of where the athlete is at, right? Like, so if you test them kind of fresh and calm, you may be not properly judging kind of where they're at, and if there are deficits that need to be addressed, obviously for their health and then possibly return to play, right? So that was something just to make folks aware. And then, of course, kind of figuring out how we might test subjective visual vertical, maybe again, not the same day, depending on how much time it takes to do the proper amount of trials. And then I like to do...
Yeah, really, it doesn't take that long to do. It's just 10 total. So
okay. All right.
Like 5 to the left, 5 to the right. So it's not, you don't have to do that 10 times.
How long would you say that would take you? Like, because I know you're really good at it.
It doesn't take long, like maybe 5 minutes.
Okay, that's good to know.
Yeah,
so depends on what else. So it depends on how long of a history they have, but
yeah, you just have them close their eyes. You put the bucket over their face, turn it, and you say, "Tell me when it's straight up and down." Say now, and you turn it, and they go now. You write it down, and then you go, "Okay, close your eyes."
Got it.
Yeah,
cool. That's good.
So
to know.
It's really an easy test. Yeah.
Yeah. Awesome. All right. Yeah. Definitely want to add that into more regular practice for me. It's something I hadn't done as much because I think, again, if you're not used to doing it as part of your run through, you're just like, oh, I don't know if I want to take the time for that because you're not as savvy. But I think if you kind of get comfortable with it, sounds like it's pretty efficient.
I like the word savvy. That's Graham's app's name.
Might not have been on purpose. All right.
Shameless
plug. I know. I love them. All right, so peripherally, I'm still going to do a head impulse test personally, bilaterally, if I think it's going to be tolerated in someone post-concussion, just to make sure someone's looked at that, again, especially if they're coming into me without any other previous testing. I might do the horizontal or vertical head shake test. Vibration-induced nystagmus test is optional. More I tend to do that if I have someone who I really suspect a hypofunction, but I'm not getting a good head impulse test personally. Because I don't have VHIT or anything cool like that. And then always checking for BPPV, hopefully within the first couple sessions, just to kind of rule that out ideally. Exercise tolerance testing, I know is pretty highly recommended in our post-concussion patients. And then again, that might not be the first day, because if they do the full 15 minutes, that is a longer one. And do you have any tips on exercise tolerance testing while we're on that bullet point?
The treadmill protocol, the Buffalo treadmill training protocol, or the cycling protocol, I think is gold standard. I think it's super important because, you could have an athlete with concussion who, their heart rate is exactly the same, but then their kind of score that they give would be totally different based on how they feel at that heart rate. So yeah, I think it's important.
Definitely. Agreed. I always look at the neck. I think you can really avoid that. And it's good to check that out. And then, of course, your balance testing. So it sounds like they might top out on the modified CAT-SIB. So then you could do the best was suggested, which includes things like single limb stance, eyes open, closed, and heel to toe on uneven surface, things like that. Or if you have that SOT computerized, that's great. And for dynamic, I feel like athletes often would top out on a functional gait assessment. So I know the high mat has been suggested as one, or dual tasking has been a hot topic. What do you think on that kind of higher level folks for dynamic?
Yeah, I agree that, we need a more difficult, higher level test for our athletes. But I think the FGA is good for now. Yeah. I mean, because some of them are going to have trouble with the tandem walk, with the, they may become symptomatic with the walking with head turns. So I think there are some items on there that are very helpful.
Great. All right. So, I mean, I know there might be orthopedic stuff, but of course I left all that off. So, is there anything else that kind of comes to your mind that is missing, or that you want to make sure that you check or ask about for our folks coming in the door with concussion, especially athletes?
No, the convergence is important to actually measure to make sure they have that good convergence, because that's another objective outcome measure that is able to be treated with vision therapy, with the pencil, with the Brock string exercises. So if it's greater than 6 centimeters from the ridge of the nose, you may want to give them the Convergence Insufficiency Symptom Survey, which is you can get it online for free, CISS. And it has some questions about how is their reading causing, when they read, do they get headaches? Do they have trouble reading? Things like that. And if they get a certain score, then that it should be referred to an optometrist to help them with that. So, but I think it looks great. Yeah.
Okay, good. I'm glad I'm not missing too many things. It's always I feel like no
matter, not at all.
The literature is always evolving with concussion, so it feels like it's like always a timely topic and good to check in. But that survey is good to mention. That's a good thought to put that in. So I know, in conclusion, as I like to say, we do want to treat any area that shows deficits or needs care, not just VOR cancellation or subjective visual vertical and horizontal, and not just the SOT. But it's good to be aware of what might be abnormal in testing, which your studies so wonderfully helped us to understand better. But it's very comprehensive care, in my opinion, when we're looking at folks with concussion. Often there's other members of the team, like you mentioned, vision therapy from a neurooptometrist, things like that. That we might want to put into the mix. So it can feel a little overwhelming. I still sometimes feel that way, and I've been treating people with concussion for a long time. So if you feel that way, whether you're very experienced or new, it's normal. We try to take each piece and just kind of think and kind of put it together and see what makes sense as best we can. And then again, kind of refer when appropriate to kind of fill in gaps, I feel like, with anxiety and mood, or, if they do need somebody can really address more the cognitive piece or what have you. So just kind of continuing to take care of those folks. So we're going to switch to our live Q&A. Very exciting. All right. Look, Dr. Cochran, full of comments. I love it. right, let's see. I got to fill in here. So, reading quickly. The computerized DBA seems to be faster, which equals less symptom provocation, especially for concussions. It's kind of more of a comment,
Yeah.
but still helpful. And an eye trout and a metronome could be definitely a viable option, is what he's saying there. And then, not as savvy. He's cracking up about our reference to his Savvy app. Something important for this discussion: VOMs and vestibular dysfunction aren't necessarily the same, and that's a very good point. But both
Yes.
are important. Symptoms during VOR testing matter even if VOR gains are normal. So that's a really good point, that we care about symptoms during testing, like what we look for in the VOMs is about provocation, right? So let's see. Crystal has a question here. In treatment, do you use a specific subjective guide for symptom provocation? Like challenge them to a certain threshold, but don't wipe them out. This is a great question, and it comes up often.
Yes. What we did in this study was we did a 0 to 10, and, related to symptoms, dizziness, headache. And if they either requested to not do the test and to stop, or if their symptoms increased more than, I believe it was 2 points from their baseline, then we stopped the test. So yeah, I mean, especially with headache, that is super important to not induce their headache with your testing. So I agree that we need to that you need to keep an eye on those symptoms after every test, after every exercise. Really, keep an eye on those symptoms for sure.
Got it. And then is there a time frame, like it needs to settle back to baseline within a few minutes, something like that? I've heard people suggest that. What are your thoughts on that?
Mm-hmm. Yeah, I don't think that there's a complete standard on that. I think using your clinical judgment, definitely if symptoms last more than 20 minutes, that's way, way too much. Then you did too much. You need to back off. But yeah, let them settle back down before they move on. And then teaching them to do that also when they're doing their home program.
Yeah, definitely. And I think what's tricky, and you've probably all experienced this, unfortunately, is sometimes we get this delay or accumulation type situation. So it's always a challenge, I think, to walk the line, as I like to say to my patients, and sometimes we might cross it and, have to stop or lay down and do leg exercises because we kind of, did cross it unintentionally. So, just kind of hope that it'll settle and then learn from that to try to adjust what you do the next time.
Yeah, we actually did more than 3 points. We stopped, but another related to what you just said, on the other end of the scale, you don't want them being hyper focused on their symptoms either, because that could turn into kind of a 3PD type of situation where they don't want to do anything, so you gotta use that beautiful clinical judgment. Work with your patient.
Definitely. Good point. I think I saw another question that was asking about balance assessment, kind of further up or down. So it was something to the extent of, we talked a little about different dynamic balance assessments. I know you kind of seem to favor the FGA. If we really think that the FGA is not going to kind of cut it, or it's kind of just, they're going to top out, but there's deficits, especially again, they're an athlete. They really need to be able to do a lot. What would you say are kind of your standouts that you would do there?
For dynamic balance.
Mm-hmm.
And this is just, I'm just thinking, look at what their sport is and do some things related to their sport. Maybe it's not a standardized outcome measure, but if they are a football player, do some drills that would require them to have balance, shuffling side to side or doing some things like that related to their sport. To me, that would be important to them to be able to do that.
Yeah, and relating to function, Vestibular Health suggested another option would be the Community Balance and Mobility Scale.
Mhm.
even though it takes time to perform, but there are matched norms, and it's validated in TBI at least. So
Okay.
I think it's good to
Yeah,
think about.
there's so many great
Yeah,
outcome measures out there.
yeah.
Um,
And I love ones that are function based because obviously that ties right back into, what the patient might be dealing with or trying to achieve or their goals and things like that. So it's nice if it fits into a scale that you already would want to know if they can do something like go upstairs carrying a little
mhm,
laundry or whatever might be on a scale. I'm just kind of putting that out in there, but as an example. So
mhm.
good point. I had another question here. How do you advise patients with light sensitivity? So this is kind of a
Mhm.
different issue, but it can come up during testing even.
Um, so, so I'm not really sure. So the question is, how do we, if they're light sensitive?
Yeah, do you let them wear sunglasses? Do you keep the
Oh,
lights
absolutely.
dim? Yeah, any of that stuff's okay? Yeah,
Absolutely. Yeah. I think it's important, especially right at first that you have your clinical environment to be very calm, not too bright of lights, dim those lights, let them wear their sunglasses if they need to. Um, because that's one thing that's going to induce that headache that you do not want to induce.
right. All right.
So,
Good point. Good point. All right. So let's see.
so
Graham
that settles down.
has a little something for us. Doing sports
Okay.
specific drills can also help them better understand how their balance issues may be affecting their return to play better than our clinical tests of balance. That's a good point
Mhm.
from Graham. And then a question
Very
here
good.
from,
Now.
I know, right? And then a question from Crystal. Do you all measure cover on cover or cross cover for trophias or phorias and refer them out, I think, for vision therapy?
Yes. So if I suspect that they would have atropia, I mean that's such an easy test to do in your vision screen. You could test for skew with the cover cross cover, or if you feel like that they have atropia phoria, you can test that with the cover test. So yes, I think that's important.
Very, very good. I didn't have that on my assessment list, but it's good to kind of think about doing that, especially
Hmm.
like you said, if you suspect it. If I hear about double vision, although of course convergence might be the cause, I do like to maybe kind of reminds me that I want to check. Uh,
Yeah, and that may be the reason that they're having their vision issues is because maybe they need to go, be referred for some corrective lenses for that. And of course, if you see the skew, that's a definite central sign. So that's important to see as well.
for sure. So we have an input from Carrie Herrero. I like the community balance and mobility scale, but it is lengthy. I find the high mat elevates heart rate pretty high, which can trigger symptoms.
Hmm.
So pros and cons on those tests for sure. Bodies and Balance says just referred someone to neurooptometrist yesterday for a positive uncover with positive
Hmm.
exophoria and positive Maddox rod test. Getting
Okay.
prisms temporarily, it's very important to test. So yeah, so kind of agreeing
Yeah.
with you, Dr. Christy.
Good. Good. Yes.
Good. Here's a question from Crystal. Last question. Although I know the King Devic is a sideline test, I sometimes use it to check for error and symptoms. What are your thoughts on this, Dr. Christy?
Yeah, that's a fun test, and it's like you said, it's typically for pulling them from play. But as long as you have a baseline, I think with that one you do need to have a baseline on it. Um, it is, it's a good test of reaction, of their kind of their ability to look at a page and follow words, numbers on the page. So yeah, and it doesn't take that much time to do. So especially if the person is having trouble with reading, that might be a good assessment to do as well.
Got it.
So yeah, I agree. I like it.
Perfect. And then something for bodies in balance. Visual issues can cause headaches later in the day, especially for student athletes.
Mm-hmm.
You agree with that, Dr. Christie?
Yes, absolutely. Yeah. And
Yeah.
that's one thing I know that our doctors really, they hammer home, like, let's not make that headache worse, so that's one thing you want to try to control as much as possible.
For sure, for sure. It's good to give guidance because I think students and even I have a lady right now. She's a lawyer, and she's on the computer constantly, and she's struggling because her employer wants her to work, and I'm like advising her to like. Okay, it's kind of hard to give guidelines, right? Like, well, how many minutes until you think you feel symptoms? Can you take a little break when you do? Can someone help you, like, input some of the data so that you don't have to be on the screen as much? Kind of accommodations, but for work instead of for school, and kind of figuring that out as its own.
So important. We got to, it's like the brain has had this traffic wreck, and we got to let it clear. You got to give it time to clear. So.
For sure.
And strategies, meditation, breathing, all that, we all know that that's good for everyone. So just to help your brain to settle down.
Definitely. And I think a lot of my patients at least are like, well, I want this to hurry up and get better. And I'm like, yeah, we all do. But, understanding that I always say the brain doesn't like to be like pushed in that way. Like you have to really, again, walk that line, and sometimes you use the Goldilocks, like, just the right amount of input, so that it can kind of, heal itself, because there's definitely a balance between doing something to help stimulate, but also, again, not to really irritate. So Bodies in Balance is adding a 20-second break every 20 minutes is a typical optometry recommendation.
Okay.
Okay. I like that. 2020, easy to remember.
Yeah, 2020. And also, I think it's so important that they believe that they're going to get better. Because just that belief that you're going to get, even though it's taken time, it gets a little frustrating, but just believing that they're going to get better is important.
Yeah, no, and that can be a tough one sometimes, especially for the chronic ones that come in. That's really where the challenges can be heightened, I think. And I think of that all as like your brain has learned some of these symptoms in a way. So, we're trying to kind of find ways to unlearn them, which goes back to my games, because like, you're having fun, you don't feel as bad.
Right.
So, and there is some literature about, kind of the value of play. So even though I'm not officially a PT, some patients are more open.
We're all kids.
That's right. That's right. Some patients are more open to it than others, but I think, if you can get creative, and I have a gentleman right now, he's not a concussion patient, but he loves golf, and he unfortunately had bilateral vestibular loss. And so, just getting him to stand for balance is boring, right? So I'm like, all right, let's stand and like just hold the club, and then like I'm gonna put the ball, and I just want you to swing it, but I'm right here, so kind of engaging him. I'm sure everybody out there is kind of trying to find out what our patients enjoy and trying to find ways to integrate, some aspect of those things. I used to have a game that was like a magnet on a fishing pole and like little magnetic fish, and I had people who love to fish. They're like, it was a little silly, but they like kind of liked it. They're like, oh yeah, I got the blue one. It's like whatever works, right? Yes. All right, we're really close to time. So we only have time for one more question. And I don't know if there's an easy answer for this, so I'm sorry. But what are the best kind of couple pieces of equipment that one should invest in if you're going to be assessing and treating concussion patients in the clinic?
Okay. I think every clinic needs a set of goggles to look at eyes in the dark. Like you just need that. So invest in a good set of goggles. I think that computerized dynamic visual acuity is a good investment. I think it costs about $15,000. Does that sound about right? Mm-hmm. You can get a lot of good information from that, and then also a good instrumented type of balance system. So it doesn't have to be a gigantic thing. It could just be, the platform where you can measure sway to get some objective data for that. So, and then for the SVV, you just need a bucket. Like, you do not have to go out and buy expensive equipment for that at all. So that's kind of the order. Maybe I would do goggles, platform, and then DVA, computerized DVA. What do you think?
I think that's on point. I mean, like I said, DVA
Okay.
is definitely in my wish list bucket. I only treat part-time, so yeah, I'm lucky to get somebody to buy me a Marsden ball, but I think it's good, especially for someone maybe that's doing their own private practice or something, and they want to save up, and prioritize, past what I'll call the obvious, like colorful cones and rings, to kind of these higher level equipment. It can feel, again, a little overwhelming, I think, to make those decisions. So I think that's good guidance. So thank you so much, so much for taking the time to be on here, Dr. Christy. It's really helpful. Like I said, concussion, as you know, is a pretty challenging diagnosis because they can present so many different ways. But I think this helps give us even a better framework. I always learn something when I do these journal clubs. So it's just awesome to have you on to get your experience and insight. And thank you so much. If anyone needs to reach Dr. Christy, pretty sure your email is just publicly listed on the University of Alabama Birmingham website, so pretty easy to Google that one up. And
Well, thanks so much for having me. This was great.
Awesome. Thank you so much again, and we look forward to more of your research coming out all the time on different areas of vestibular care. So thank you for all your good work.
All right. Thanks for doing this. This was fun.
My pleasure. All right. You all have a great day or evening wherever you are, and I hope you got something out of this great discussion.
Yeah.
Everyone says thanks. Bye, everybody.